Hello, and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Jessica Adams. Today's episode is on emerging insights on adverse events during antiretroviral therapy and implications for treatment, featuring Dr. Fidelia Bernice from University of Maryland Medical Center in Baltimore, Maryland, and Dr. Aadia Rana from the University of Alabama at Birmingham in Birmingham, Alabama. They'll discuss ART safety and tolerability, including recent data on nephrotoxicity and safety with long-acting injectables. Following their dialogue, the faculty will field questions from healthcare professionals. Let's get started and listen in to Drs. Bernice and Rana.
So for my portion of the talk, I'll be focusing on nephrotoxicity. So we know that in patients living with HIV, it's recommended that they be on lifelong antiretroviral therapy. So we have to balance the efficacy of these great drugs with their potential side effects and tolerability issues that they might have. So we have listed here a bunch of different safety and tolerability concerns we want to think about when we're choosing antiretrovirals for our patients. But any of these topics could really be an hour long and on their own merit. So I'm just going to focus on the renal health for my portion. So how do we avoid nephrotoxicity in our HIV positive patients in whom we're starting antiretroviral therapy? Nephrotoxicity, we namely think about with the nucleoside reverse transcriptase inhibitors, or NRTIs, as I'm going to say for the remainder of the presentation, and namely with our tenofovir products. So we know that TDF is associated with renal injury, and it's recommended to actually avoid in patients with a creatinine clearance less than 50 mLs per minute. Now, this formulation has been upgraded to the newer, safer option, tenofovir alafenamide, or TAF. And in combination with other antiretroviral agents, it's recommended to avoid if a creatinine clearance is less than 30. If you review different combination products, you'll see that there are actually differences, and there actually are some exceptions for which TAF-containing products you can use in hemodialysis. So the combination of bictegravir, emtricitabine, and TAF, elvitegravir with cobixistat, emtricitabine and TAF, and as well as rilpivirine, FTC, and TAF can be used in hemodialysis. We know that abacavir can be used without regard to renal impairment, so that's good for our patients who have concomitant CKD and things like that. It can be used if they are HLA-B5701 negative. And we think about lamivudine. It does recommend it to be renally dosed, but it's actually not associated with renal toxicity. And even in clinical practice, it's actually common not to follow the package inserts labeling and give more than is recommended, basically for ease of administration and focusing on adherence in our patients. Emtricitabine, which we know is also a structural analog of lamivudine, is also recommended to be renally dosed. But again, you will find inconsistencies in the package inserts as to what you should do and which products can be given. So I'm going to focus a little bit on lamivudine. It's common practice, I know in my practice and other places I've seen, to give more than recommended because we essentially want to give patients the easiest tablet size to give them instead of avoiding having them to dose with the liquid formulation. So this study actually looked at the safety profile of giving higher than recommended lamivudine doses in patients with renal dysfunction. So you'll see here about 34 patients were included, men and non-pregnant, non-lactating women who were adults and had been receiving lamivudine as part of their regimen for at least 3 months. At various creatinine clearances, they had decided to give more than recommended. So if your creatinine clearance was 30 and above, you got full dose at 300 milligrams daily. 15 to 29, you got 150 milligrams. And for the hemodialysis patients, they got either 100 milligrams or 150 milligrams. And they did pharmacokinetic analysis to see what were the concentrations, both Cmin, AUC, and Cmax in these patients. And what they found was that the observed Cmax values were actually comparable across the all 4 creatinine clearance cutoffs. And they did see slightly higher Cmaxes in those with worsened renal dysfunction, but it wasn't clinically significant. And when they evaluated things such as lactic acid levels, they actually found that they were all within normal limits. Again, so demonstrating the tolerability of giving higher than recommended lamivudine doses in our patients with renal dysfunction. And there were no reported adverse effects. Patients in this study had been receiving lamivudine for at least 3 months, but there was actually a bit of variety in how long they had been receiving lamivudine. So some had been receiving it for multiple years. So it wasn't like they had just started. So giving us options for our patients who have renal dysfunction, we can give them full dose lamivudine, which it kind of just validates our current practices that we're doing anyway. So when we think about nephrotoxicity in our HIV positive patients, we want to think about sometimes we want to think about nucleotide sparing regimens, namely tenofovir sparing regimens. And we have done this a lot through dual regimens. So I'm going to talk briefly about the Gemini 1 and 2 trials. So these studies, large international randomized controlled studies, they were identical, evaluated the use of starting treatment-naive patients with dolutegravir and lamivudine, comparing that to dolutegravir with the traditional two NRTI backbone of emtricitabine and tenofovir disoproxil fumarate. Evaluated at various time points, including the primary endpoint was week 48, but we have data up to week 96, and there's currently analysis through week 144. And what we're seeing is that starting patients with the 2-drug regimen of dolutegravir and lamivudine is actually non-inferior to starting them with a standard 3-drug tenofovir included regimen. And this is important because some of our patients might present with having concomitant CKD already, right? So potentially don't want to give them something that could worsen their CKD. This is a great option for treatment-naive patients. They also looked at changes from baseline in renal biomarkers. And they saw that in the tenofovir group, the 3-drug group, there were statistically significant decreases in eGFR and statistically significant increases in their serum creatinine, namely attributed to the tenofovir disoproxil fumarate. In moving on to the SWORD 1 and 2 studies, this evaluated a different nucleoside sparing regimen, dolutegravir and rilpivirine. So this was actually a switch study. So they compared switching patients to a 2-drug regimen consisting of dolutegravir and rilpivirine in those who were already suppressed to continuing a baseline 3 or 4-drug regimen. And they looked at the primary endpoint of maintaining viral suppression, a viral load below 50 copies per ml. And in both groups, they found that this was non-inferior to continuing the standard 3-drug regimen. And again, in this study, they also looked at biomarkers for renal function. And essentially, they compared those who had a TDF regimen initially to those who didn't. And in those who did have a TDF regimen, they essentially experienced improvements in their renal biomarkers when they switched to dolutegravir and rilpivirine. Again, giving us data that this is a good combination for our patients who potentially are at risk for nephrotoxicity or have concomitant renal issues. So with that, I'm going to turn it over to Dr. Aadia Rana, who's going to talk to us about the safety and tolerability of our newest long-acting agent that's come to market.
Great. Thank you so much. So thanks to everyone for joining us today, this morning, this afternoon, depending on where you are. So yes, as she mentioned, I'm going to be talking a little bit about the long-acting agents, cabotegravir and rilpivirine, these new agents. I know everyone is excited to use them, but they are new. So I think there's also a little bit of hesitancy and concern in particular about these agents. They were just FDA approved actually earlier this year in January of 2021. So we thought we would take some of this time to review the data that is now currently available, both in terms of the clinical trials that led to its approval and also some data that we have now in the aftermath of its approval. So just to start off, again, this is injectable cabotegravir and rilpivirine. And the 2 studies that were that tested the use of these were ATLAS and FLAIR. ATLAS was a switch study, so people were already stable on their current regimen, did not have a history of resistance to the regimens included in cabotegravir and rilpivirine, and then were switched to injectables after tolerating a month of oral rilpivirine and cabotegravir. And then FLAIR was the treatment naive study. So participants who enrolled in that study were initially started on a regimen of oral abacavir, 3TC, and dolutegravir fixed dose regimen, and then were randomized to either continue that regimen or to start the injectables, again, after a monthly oral lead-in period of the oral version of cabotegravir and rilpivirine. And as you can see in this slide, the virologic outcomes in both of these studies, comparing the oral regimen versus the long-acting, were excellent in both groups. So equivalent, over 90% virologic outcomes at week 48 in both ATLAS, which again was the switch study, as well as FLAIR, which is the treatment-naive study. And then when we look at the safety outcomes, comparing the long-acting with the oral agents, really not significant differences in the two. Both oral and long-acting were fairly well tolerated in terms of the stage 3 or 4, so the higher level adverse events. Those who were on long-acting in the ATLAS study, about a little higher rates of things like fatigue or headache or nausea, about 4% compared to 0. But again, these were people who were starting a new regimen versus who were continuing on their baseline ART. Comparable side effects reported in the FLAIR, again, the treatment-naive study. So overall, fairly well-tolerated regimens. The thing that people were most concerned about were the injection site reactions. So injection site reactions were the most common side effect reported, certainly in the long-acting groups for both ATLAS and FLAIR. Most participants reported some level of injection site reaction, with the most common one being pain, and a few reporting things like nodules or induration, swelling, as well as a grade 3 injection site reaction or pain, only in about 1 to 2% of these participants. The mean duration of the injection site reaction was 3 days. And most notably, however, the injection site reaction led to a discontinuation in only about 1% of these participants. So most of the injection site reactions were grade 1 to 2 severity, and most of them resolving within 7 days. There are, I don't have the slide here, but in general, when you look at the graph of the reported injection site reactions as the study progressed, by the end of the study, there were fewer and fewer participants reporting injection site reactions. So really, it was the first few doses where participants were even reporting a lot of these injection site reactions here. And now there was also a process of looking at what is called sort of the direct to inject. So as I mentioned in the ATLAS and FLAIR studies, participants, you have to be suppressed before you start the injectable regimen. And even after that, participants are given an oral version of the cabotegravir and rilpivirine prior to starting the monthly injection. And again, that is due to concern for, safety and tolerability of those agents before you administer long-acting. So participants in the FLAIR study, the treatment-naive study, who were originally randomized to continue on the oral version of, just abacavir, 3TC, and lamivudine daily, were then offered at the end of the primary endpoint to transition to long-acting. And those participants were offered the option of either doing the month of oral cabotegravir or rilpivirine, or going direct to inject. And so this was only eligible for participants who had achieved the viral load less than 50 copies and were at week 100 of FLAIR. So about 121 participants decided to still take the oral cab and rilpivirine, and about 111 decided to forego the lead-in. So they went directly to injection. And in terms of virologic suppression, really no significant difference. 99% of those who did not have the lead-in still had maintained their virologic suppression compared to 93% of those who did have the lead-in. But I think the other thing is to note is that there was no real safety issues in this population as well. So really, they did well in terms of virologic suppression. And then, and likewise, for safety, there were really, between the direct to inject and the oral lead-in, no liver monitoring or any stopping events, no confirmed hypersensitivity reactions, or other significant dermatologic manifestations that we would have been concerned about in administering long-acting to these participants. I think the other concern for use of these long-acting is certainly, as I mentioned earlier, participants have to be suppressed per the current package insert before starting the injectable regimens. And there have been questions surrounding whether that is truly necessary. This is a 2-drug regimen of cabotegravir and rilpivirine. And so, is it possible, given now some of the data that we have with Gemini and other studies on 2-drug regimens, is it possible to do a direct to inject approach, which does not require the patient to be virologically suppressed? So there was data that was presented at IAS last year, as well as the HIV Glasgow meeting, which presented on the compassionate use of long-acting cabotegravir. So this is a program where providers applied to the companies to get access to parenteral ART. So about 35 patients were included. Over half were female, and 80% had detectable viremia at baseline. And this was a challenging population. The median CD4 count was only 100. And of this challenging population, at the last follow-up that was reported in the study, 63% did have a viral load less than 50 copies at last follow-up. So 5 patients withdrew from the program, including 2 who had become suppressed after stopping long-acting cabotegravir and rilpivirine. And injection site reactions were the most common adverse event, though no person withdrew due to the injection site reaction. 5 persons did have significant adverse event, although only 1 was felt to be treatment related to loss of consciousness after the administration of the injection. And then this past summer, as this has been approved, and as well as sort of being reviewed by our insurance companies here in the US, there is a implementation effectiveness study of the use of long-acting cab and rilpivirine injection that was also presented at IAS this summer. So this is a hybrid 3 implementation effectiveness-based 3B study. So this is US-based, taking place in 8 clinics across this country. 2 of them are federally qualified health centers, 2 are university-based clinics, 2 private practices, and then as well as an HMO and an AIDS Healthcare Foundation clinic. And so what they did was they interviewed both providers and clinic staff, as well as patients who were started on the monthly regimen, and to really get a sense of questions surrounding implementation of this strategy at the clinic, as well as acceptability of the use of these agents by the patients themselves. So among these 8 clinics, 115 patients were started on the injectables. And again, the DHHS guidelines on the use of these agents, which includes patients who, again, have achieved virologic suppression, don't have a history of virologic failure or evidence of resistance with, of either a predicted resistance with either of these agents, rilpivirine or cabotegravir, would have been eligible to start on the injectables. And as you can see, of these 115 patients, most 88% both achieved and maintained virologic success. And it was really consistent with the phase 3 data. Fatigue and headache were the most common non-injection site drug-related adverse events. And 2% of the patients withdrew due to injection site reactions. 93% of the patients thought time spent in the clinic for long-acting injections was extremely or very acceptable. And I think as the clinics became used to sort of the processes and the procedures of both administering the injections and patients receiving the injections, the median duration of the visit length decreased over time. So almost an hour at month 1 to about half an hour by month 11. The other thing I will point out, and this was mirrored in the phase 3 studies, is that acceptability of the treatment was extremely high, even from month 1 to month 12. So over 90%, 91% of patients were excited and really excited about starting injectables. And by month 12, that number only improved to closer to 98%. Now, with both the phase 3 studies and with this study, we are talking about participants who are very interested in using injectables and are very motivated. So, sort of not a broad swath of the patients that we're necessarily treating, so very motivated patients. And so I think questions still remain about sort of broader use and broader implementation of this strategy. So looking forward to discussing some of these issues with you all. Certainly can take this opportunity to plug a study that is still ongoing in ACTG, the Latitude study, where we are looking at the long-acting strategy in participants with a history of non-adherence. I think that ends it for my session for now, and we'll go to the Q&A session.
Yes. So we've got a question in, and feel free to ask questions. And if not, I think the data that you presented was very interesting and we could have a whole discussion about that. But Alejandra asked, would you recommend changing to 2 drug regimens containing rilpivirine if a patient's viral load is less than 50, but the CD4 hasn't recovered and is still less than 200? So it's a really great question because we know that in initial studies where rilpivirine came to market, we had lower response rates in those who had elevated viral loads and as well as those who had low CD4 counts. Now, if they're already virally suppressed, the viral load's not as much of an issue. But should we think about the issues with rilpivirine in this low CD4 count? I understand the hesitation for some providers to want to use rilpivirine in patients with low CD4 counts, but I would say that one thing to consider is it is harder to attain viral suppression than maintaining it. So in certain situations, it might be appropriate. And then we know that we have patients who don't fully reconstitute their immune system, no matter how long they've been on therapy. So if they would be a good candidate for a rilpivirine-based regimen, it might not be the only reason I opt not to. However, if you can also get away with dolutegravir and lamivudine and you're more comfortable with that, I don't think that that's wrong either. But I will say I've definitely done it in practice.
Yeah, I agree with that comment. I think that if the viral suppression for me is the bigger key in terms of even that restriction. So as long as somebody has achieved viral suppression, just as you said, Dr. Bernice, and is, and now we're considering the switch at that point, I feel very comfortable. I don't hesitate at that point to do it, go ahead and do the switch.
That was the only question we've received so far. But I was interested in your, I guess, clinical experience with using the long-acting so far. I've polled everyone that is using it to see what's happening, and I hear different things.
Yeah, so it has been, I think, an interesting adventure since January. So in my clinic, we have not started using commercial cabotegravir or rilpivirine as of yet. Some of the barriers or the bigger barrier right now has been sort of the insurance issues that are surrounding it and the cost related to that. So there are things that we are sorting out, and I think discussions that have been going back and forth. In the implementation study, I didn't present that data, but there was a lot of questions with regards to who is going to make sure that participants come in on a monthly basis. And, who's going to keep track of that? And are we going to be selecting the correct patients? So what kind of structure do we have to have in place? And so I think similar to, in our clinic, we have women come in for their Depo-Provera injections. And we do have somebody who's assigned to do that particular task. So I think we're still in the process of doing that, but our biggest limitation was concerns with regards to the reimbursement structure. And I think as that sorts out, we will be using it more commercially. We're actually sort of triaging it to participants who are coming off of study first. Will be the first ones to get our clinic administered injections, and then we'll be going into discussing with our patients with regards to those who want to on their own come up on that. But I think it will continue to be a long discussion with regards to processes and procedures. The other point I'll go ahead and make with regards to that is the other thing that's under review with the FDA is administration of the injection every 2 months rather than every month. And so that is still under FDA review. And I think once that data, which the data has been presented and showed to be efficacious, I think that might be another thing that may increase acceptability of clinics to be willing to have, patients come in every other month as well.
Definitely.
So I think we have a couple of questions now with regards to the long-acting. So there's a question. Thank you, Alicia, for your question. So in the long-acting CAB and rilpivirine compassionate use study, was the SAE of loss of consciousness attributed more to RPV or cabotegravir? So I don't know if in the presentation they made that distinction. I will say that there was in the phase 3 study a report of unintentional intravenous potentially administration of RPV, and that was determined by blood levels that were collected where there was a vasovagal event at that time, and so that and that was RPV at that time, but I'm not sure with regards to this, again, one case of loss of consciousness, was it considered related to the injection itself? Was it a vasovagal event, related to just receiving an administration of an injection, as can happen? So I'm not sure if that clear attribution was made between RPV and CAB.
We We have another question from Winnie. She's asking, are you using the lead-in PO cab or cab rilpivirine, or just going straight to injection? I know in my clinic, they are doing the PO lead-in.
Yeah, so currently I'm going to emphasize DHHS guidelines, FDA package inserts still, recommends the oral cab rilpivirine lead-in prior to straight to injection. Now, but there have been cases, again, such as in the compassionate use and other sites around the country that are in a, certain patient population deciding to forego the oral lead-in. And I think that's gonna, that can be considered on a case-by-case basis. If I have a patient who has sort of a proclivity to having, adverse events, I probably am gonna go ahead and use the oral lead-in. If I have somebody who has been tolerating, in particular, the contents of the injectable, say, for example, somebody who's been on dolutegravir or rilpivirine and has been doing just fine with that for some time, I don't necessarily see a need to give them the oral, version of cabotegravir and rilpivirine again. They've already tolerated it. But I would still have that conversation with the patient to see, how they feel. But as a clinician, I would feel very comfortable not necessarily giving that, patient the lead-in. I think as we gain more experience, we can learn from that. But I think there are going to be cases, in the details of the compassionate use, there were some patients who were just intolerant of oral medications, and so they, did not use the injectables. Sorry, they did not use the oral and went straight to injectable. But in certain cases, I think it probably is okay to go.
Mm-hmm. We have another question from Winnie. If we switch a patient from dolutegravir, bacavir, et cetera, straight into injections, is the original regimen continued for 1 month or stopped right away?
So it's stopped right away. So, you take your last dose of and this is going by what happened in the phase 3 studies, you take your last dose of your medication, oral medication the day before, and then you are administered what's called a loading dose. So it's a slightly higher dose of the injectables, and then you're monitored after that. So that it would just be like, if somebody was on some oral birth control and then went to Depo-Provera, they're on Depo now. So it would be very similar.
Ralph is asking, what do you see as compliance issues for general use of injectables?
Yeah, so that's a great question. So why don't you start, Dr. Bernice? Go ahead.
Yeah, I think the one thing that I've heard from my lights went off, that I've heard from some people who are starting to use the combination injectable is getting people into clinic for their regular visits, not just their injection visits, right? You have to make sure they're also seeing their providers and being monitored labs wise and things like that. And then everyone is also afraid of what if they, just stop coming to clinic and they potentially don't have any oral to cover them or don't know to start taking orals to cover them. So I think those are the biggest issues that I've identified thus far.
I agree. I think there's certainly a lot of concern with regards to adherence to the regimen, and then the concern for resistance development. So both rilpivirine and cabotegravir, they have what's called, the tail. So once you administer it, it stays in your system for some time. Cabotegravir has a longer tail. So if somebody stops coming for their injections and, as you mentioned, does not start taking oral medications at the same time, there is this, possibility that they will at some point just be on cabotegravir, an integrase inhibitor by itself. And so because of that, could you then potentially develop high level resistance to integrase, which is our a very well tolerated, first line regimen for all of us. So I think, communication with your patient, good clinic procedures, and I think again, as we mentioned earlier, a dosing interval that allows for some forgiveness, the dosing windows, as it were. We talk about more concern at the beginning versus losing them at the end. But I think as we gain more experience, we'll learn. Anytime we have a paradigm shift, there's a little bit of hesitancy, and I think a lot of theoretical concern, but at the end of the day, we got to meet our patients where they are. So we can sit here and you and I as providers can be sort of very patriarchal and think about, it could be this, it could be that. But at the end of the day, when our patients ask for something, I think we got to see how we can make it happen.
Absolutely. Winnie asked,
I'm sorry, Dr. Rana, I think that's a really good segue. Do you want to talk about the treatment emergent resistance that came up with long-acting CAB and rilpivirine in the clinical studies? Was that something that was of concern?
Sure. So certainly, again, like that, I think, and I'll just pull up this slide. This is data from the phase 3 study. So this was, with an entire caveat of this is a very select motivated patient population who chose to be part of phase 3, studies. And there was very little resistance that was reported, even emerging resistance in this population. So pooled in both ATLAS and FLAIR, there were 6 reported cases of failure for which they were able to document resistant strains. And these are listed here. So these were all in HIV subtype A, mostly in subtype A1. And for these participants, only a couple had the baseline NRTI resistance. But they also had a baseline L74I, which is in sort of a felt to be non-significant INSTI mutation. But when they actually went back and looked at all participants who achieved HIV-1RA less than 41, this L74I was not, even though it was present in those participants, they had no problem achieving week 48. So we're not sure if it's this interaction with this particular subtype and this, particular INSTI, mutation. And again, the numbers aren't that high. We're still talking about only 6 participants total. So it's hard, and only 5 who had this particular mutation. So I think in general, we still have, data to be collected. The other point I think is that after week 48, they continue to follow participants up to week 96, and really no additional cases of treatment emergent resistance were reported. And again, this very motivated, pre-screened, trial participants.
We have another question. Winnie asks, once you start the injectable, how often or how soon should the viral counts and CD4 counts be checked?
So good question. I would say that, you would follow sort of clinical practices as you're doing. Once I start the injectable, I would probably have the participant come in at a 1-month time point. Because they're coming in, obviously for their injection. I would probably check a viral load within sort of 6 to 8 weeks after the first injection. And you're checking to make sure there's tolerability. And then after that, probably, within 3 months or so. And then, we would sort of go into our regular frame. And again, that's depending on which patient we're talking about. Are we talking about someone who's been very well tolerated, doing well, no history of resistance, versus somebody I'm like, okay, you've had some challenges, let's go. You're coming in anyway. I'm going to check more frequently. And the CD4, I would follow CD4 guidelines. Like if somebody's CD4 is high and they've been high, I'm not as worried about what's happening with their CD4. I'm more concerned about what's happening with their viral load.
Yeah, I agree. Especially after switching therapy, whether it's long-acting captopril or rilpivirine, you want to make sure that they don't have viral rebound. So completely agree. And I think to highlight those differences in patient populations, I think that's very important specifically with this particular regimen, because again, a lot of the data that we have seen with CAB rilpivirine has been in a very specific patient population, and it's not always a patient population who we might want to use it in.
Thank you to Drs. Bernice and Rana, and thanks to you, the listener. To listen to more episodes in this series and to see slides and modules on emerging insights on adverse events during ART and implications for treatment, see the links in the show notes. Thank you and have a great day.